By the time you leave today, you will have a whole lot more knowledge about anything that you're wondering. Okay? I started out with this because in any given area, there truly are a whole bunch of plastic surgeons, as you know. And one of the things that people have difficulty with is, well, how do you pick a plastic surgeon and what is important and what is not? We're lucky in that in this general area, in the Puget Sound area, there truly are many, many qualified plastic surgeons. So what I always tell every patient that comes to see me is I encourage people to see multiple plastic surgeons and to interview them. Because plastic surgeons, we're sort of like artists in our own right. And just like if you were to take 10 artists and say, draw me an apple, you'd get different renditions. Well, I think with plastic surgeons, you kind of get different renditions as well. So it's very important for you to interview, make sure that you connect with the plastic surgeon, look at photos, make sure that you ask questions, and I always say that plastic surgery is an experience, and it's made up of not only the surgeon and whatever their artwork may be, which you would see by looking at photos, but the staff, the facility, preoperative visits, post-operative visits. It really is a whole package. So the only way to do that is really to look around, and whatever your gut tells you, whatever works for you, is the place that you need to be. Okay? So, in terms of breast implants, are you a good candidate? There are a lot of questions that the plastic surgeon will ask you as well. But whether you're a good candidate or not, ultimately really depends on not only your anatomy, but a little bit of the psychological aspects of why we want implants. So the things that are important to me for any patient is, have you gotten enough information? Have you thought about pros and cons? Because anything that we do electively, there are always two columns. There's all the benefits, and then there are some trade-offs. And within those trade-offs are absolute risks and complications that you really should think about and get information on, etc. Then psychologically, it's not a decision that we want to go into overnight. We definitely want to think about it, sleep on it, and then determine if it is a good thing for us to do, looking at all of the pros and cons. And of course, it's also very important that you do it for you and not for someone else. It's good to ask yourself questions before you go in, even for a consultation, and I've listed some of those because those will be helpful in communicating with the plastic surgeon in terms of thoughts of what size do you really want to be, what are your expectations, what are your fears, what are your concerns, why you want the procedure. Other things are, even when people think about size, I think for a plastic surgeon, I know I really appreciate when, I'm a visual person, so I really appreciate when patients come in with either photos of what they feel is proportionate to a particular picture that they've pulled out for me, a bra that they want to fill in. Those are important. And in addition to that, I always ask some questions because it is my job to try to get inside your brain in order to determine exactly what you want. The more that I can get in there, the better I can create your expectation. And that would be, I always ask, if I had a choice, would you be more upset if you were just a little bit larger or a little bit smaller? Because those will help me determine, and if I had a little bit of a leeway, which way I would rather take you. Okay? So, whenever we think about breast implants, in my mind there are two true risks, and those are things that we really have to come into terms with before determining if breast implants are for you. Number one is capsular contracture. While I'm talking about this, have any of you guys listened to that little video thing on my website? Okay, so some of this is going to be a repeat, but I think it's so important that it's probably worthwhile. Capsular contracture, do you all know what it is? Okay. Anytime we have something that is foreign to our body, and that could be a breast implant, it could be a sliver under your skin, anything, it could be an artificial joint, your body will actually recognize it as being foreign to you. And in order to wall it off, it will create scar tissue around it. That scar tissue happens in everybody, male, female, it doesn't make any difference. And it is actually a protective defense mechanism of the body. In some individuals, that scar tissue around an implant and around other foreign things as well will thicken and it'll start contracting. When it does that, that is called capsular contracture. So as it contracts around anything that is solid, it won't make a difference. But a breast implant is something that is soft and moldable. Because the breast implant is soft and moldable, as the scar tissue starts shrinking, it puts more pressure on the implant. And so the first thing that the patient would notice is that if you feel the implant, it starts feeling firmer. And if it continues to shrink, the whole shape of the implant will change. And I always say implants are like fat pancakes. So if you get capsular contracture, the implant will become more and more like a squeezed ball. And when that happens, obviously when you look in the mirror with an implant, that breast is going to look different. And typically it will get narrower at the base and it will become more projecting compared to the other side. The issues about capsular contracture is that we really do not know what causes it. So our frustrations are we don't have a way of predicting it and we don't have a way of preventing it. We only know a few things that will help decrease the risk, but we don't have anything that will make it zero. And out of all the things for implants, the capsular contracture is probably, because we don't really know what causes it, it's probably the most frustrating for the patient as well as the surgeon. If we get it, typically we really do have to go back in surgically and remove the scar tissue. But then the frustration is that sometimes the capsular contracture occurs again, and sometimes we're done with it and it doesn't happen again. But that inability to predict one way or the other is frustrating for both the patient and for the surgeon. So, as far as causes, and on the video I've kind of listed a whole list of them, but we know that scar tissue in our body, it doesn't matter where it is, it's influenced by many, many different factors. Certainly genetics probably plays a role, but in addition to that, we have things such as hormones, immune system, our nutrition, our medications, etc. And when we look at all of those factors, we also know that most of them change within a day. So it's impossible to say what combination of factors really develops the capsular contracture. And that's why we haven't figured it out yet. And that has been the number one issue that has actually been researched more than I can tell you compared to anything else, and we still do not have an answer. Okay. So with capsular contracture, I listed a few things that with some of the studies we have seen that ultrasound, which is also used for like muscle spasms and scar in muscle from trauma. Do you guys know about that? If you go to physical therapy, sometimes they'll use an external ultrasound in order to break up scar tissue. And we have seen that in some capsular contracture patients that ultrasound can help. And in fact, just a few weeks ago, the National Society for Plastic Surgeons met in the Seattle Convention Center. And there's a company that has developed an ultrasound machine which is actually it's designed for breast capsular contracture. It has sort of like two paddles so that the ultrasound can impact the entire scar tissue. And actually, I was pretty impressed. Now, the machine itself is very, very expensive, so it wouldn't be, I see a few capsular contracture patients, but not very many in my practice, and that's true for most plastic surgeons. So I told the rep, I said, when someone in the area buys one, I said, let me know so I can send patients there when I have to. But it would really need to be like a physical therapist or something that buys it and then says, I have this machine, and breast implant patients that have capsular contracture can come. So vitamin E at one point was shown to also help, but it was in very, very large doses, like 6,000 international units per day. And people were doing that up to a point. And then they came up with a study that said that large doses of vitamin E have impact on the heart And so I don't recommend that anymore, obviously, because we can live with the capsular contracture, we can't live with heart issues. And then the surgical removal, like we talked about, to take care of it. And then, of course, the frustrations I also talked about. The second issue with implants, that other than the capsular contracture, is rupture. And truly, anything on this earth that is manufactured has some degree of failure rate, and rupture is that failure rate for implants. And it doesn't matter if it's silicone or saline, they both can rupture or deflate. And there isn't a time frame, just like with anything. I think in my 20 years of being in plastic surgery, the earliest patient where I had a rupture was 6 weeks after breast augmentation. That is like 6 weeks, oh my gosh. But it can happen just because there's no way of determining it. And it is a manufacturing defect. The most common area where you get a rupture is the saline implants have a little valve. It's a one-way valve. And the valve it has a little seam, and it can be somewhere within the valve area that you get a rupture. That's the most common. But that other areas would be like a little pinpoint hole. And typically those are seen later as opposed to earlier, and that's because anything that is in an implant, as long as it's not solid, is going to move around within that envelope as you move around, even though you don't feel it, and that creates a degree of friction. And that friction is going to create some kind of abrasion, and therefore if there's one area of that envelope that is a little tiny bit weaker, then you can get a pinpoint hole. So those are the reasons for the failure, and obviously it's going to deflate, whether it's silicone gel and or saline. Now, when we have a rupture, there are two aspects. Obviously we have to replace the implants. But the differences between saline and silicone, and this is, I think one of you said you wanted to know the differences, and this is a very important one in my opinion. And I'm going to go through the other differences as well. But when we have a saline implant and it deflates, or there's a hole and some of the salt water that's filling the implant escapes, you can tell almost, depending on the size of the hole, you can tell within an hour, a few days, couple of weeks, but you'll know because you really do lose volume in that implant. The salt water that escapes is going to be absorbed by the body. It isn't a bad thing, but you will definitely have a smaller breast on that side. And a lot of times I get this question, people go, if it deflates, does it just go poof and it's gone? And most of the time it doesn't. It's over a period of time, a period of days to weeks. It is not an emergency per se to have it out and to get a new one in. However, of course, it's a little bit difficult to live with one breast that's a lot smaller in volume compared to the other. So, with silicone implants, what we did find in that long period of time when silicone implants were off the market is, I think some of you might know, but in 1992, silicones came off the market, and there was, I would say, a little bit of a hysteria among the women that had them, because there are a lot of reports as to did they cause problems within the body, autoimmune diseases, et cetera, et cetera. So we went through a very long period of time where there were a number of studies done, not only here in the United States, but also in Europe, et cetera, looking at is there a cause and effect relationship to some genetic and physiologic problems that potentially could be caused by the silicone implants. And in general, all of the results have really shown that that is not the case. Probably the one thing with silicone implants in terms of why can it cause harm to the body has to do with a local problem if you get a rupture to the implant. If you get silicone that escapes from the inside of the implant to the outside, what can happen with that silicone is that it can incorporate itself, or it can travel to surrounding tissue, which is going to be muscle or breast. And as it does that, your body will put more scar tissue around it, and it will form what we call silicone granulomas. So with silicone implants, that is the reason that we want to know if it ruptures or not. But during that entire process, what we found is that mammograms are not very good at picking out ruptures in silicone implants. And if you have a silicone implant rupture, if you look in the mirror, your breast really doesn't change. And so there isn't a way that you can say, okay, I have a rupture by just looking at it or even feeling the implant. What they came up with in terms of recommendations, which I also obviously recommend to all patients that have silicone implants, is that MRIs are what are going to pick up ruptures. So an MRI 3 years after a silicone implant is placed, and then every other year thereafter. That is probably one of the things that need to be considered when you're trying to decide silicone versus saline. And we don't have this perfect implant, and so you really have to look at pros and cons, and then out of the list of things, which I will mention in a little bit as well, determine which is the most important for you. If the MRI really bothers you and you're saying, well, I'm not going to do that, then you probably want to consider a saline implant. So that's how we pick saline and silicone overall, because other than feel, I don't think there's a whole lot of difference in terms of the way that they look. Okay. There was also, prior to the silicone implants coming back on the market, there was a lot of talk out there that if you have a silicone implant, you need to exchange it every 10 years. And that we don't, there isn't a recommendation to do that. There's no good reason to do that, actually. Size of implants, I'll go through this very briefly. Ultimately, the size is really determined during your consultation, but there are certain things that impact what size implant, and it's very difficult for patients to come in and say, this is the size that I want, because if you've done any kind of research on the internet, what you will find is that you can see 2 patients, 5 patients, they have the same size implant, they all look very different, right? Have you guys seen this? So it's impossible to pick out a size even just looking at the internet. If you do look at pictures, you really have to make sure that that patient or the person that you're looking at is similar to you in terms of height, weight, and also the bra size that they wear. And it can't just be a cup size, because cup sizes are not the same. A 32C is not equivalent to a 34C, which is not equivalent to a 36C. So you really have to know exactly what bra size they are. But in general, how we determine size, I think for most people that I see, people want to be proportionate and they want to look natural. They don't want to be seen coming up the road like implants. So a lot of times people say, I don't want to be Dolly Parton. Well, you know, most of us don't. With a few exceptions, there are some areas, I think nationally, where ladies want to be Dolly Partons. And I'm going to pick Texas because everything's big in Texas. And I did my medical school in Texas, and let me tell you what, I mean, that's one area. I'm always amazed when I see presentations on breast augmentation and compare them to like my own patients in my own slides. It is so variable depending on where that physician practices. It's pretty funny. The Northwest, we all want natural, so you know, they look like natural breasts. But as you go into, like Texas, you get some very large breasts. So it's the way it goes. So proportion is dependent upon a person's height, shoulder width, obviously, and hips. And by looking at that, the taller a person is, the larger the breast they can handle without looking disproportionate. Same with shoulders. The broader the shoulders, the larger the breast can be without it looking overly huge. If you have narrow shoulders, any breast volume is actually going to look bigger compared to if you had broader shoulders, okay? And if you didn't do big enough for someone that has broad shoulders, it just doesn't look, it still looks small. So you have to consider that, in addition to the hips, because the narrower the hips, the bigger the breasts will look, and the wider they are, the smaller they will look. So proportion in terms of the overall body build is pretty important. Anatomy. If we look at, and I will show you some pictures in just a little bit about how different breasts can look. We kind of know, if you know, we know maybe we've seen breasts from our pictures or in a locker room situation, but there are so many types of breasts and so many sizes and amount of sag, etc. And so your own anatomy is very, very important in determining not only size, but what kind of surgery we do. And if we look at anyone's breast, there's going to be a certain width to the breast and a certain height to the breast. And if we want it to look natural, then we do have to take that into consideration in determining the implant size. Because implants in general, as the volume varies, so does the diameter. And that diameter is going to be equivalent to whatever we want the width and the height to be. Okay? And then what size? I always ask patients, what size do you want to be, what cup size? But there's no way to determine exactly how many cc's in an implant will give you that cup size. And the reason for that is if we look at different number bras, like I already mentioned, the cup sizes are not the same volume. And then if we look at different brands, the cup sizes are not the same volume. And as an example, Victoria's Secrets, the smaller cup sizes that they have, like the 32s, 34s, ABCs, or maybe not C's, but A's and B's definitely, they are significantly smaller volume. Like it'll say a B, but the volume that that bra is for is actually an A, because I think people feel better if they're in a B cup. Does that make sense? So it's a marketing ploy, I think, that they use. So even the brand of bra will vary on the cup size. So there's no way for any surgeon to say, I'm putting this implant in and you will be a C cup from now on. It just doesn't work that way. But on the converse side of that, if we were to take different body types, and even if every one of those body types wore, let's say, a 36, even in those individuals, because they're different heights and weights and so forth, a 36C is not going to look the same on multiple individuals. So the cup size is relative. The reason that I ask is if a person comes in and says, I'd like to be a full B, that person obviously has a different opinion in terms of what they find attractive and or proportionate versus that same person coming in and saying, I'd like to be a D cup. See what I mean? So it allows me to get into that patient's brain, I'm going to say, in terms of what it is that they desire and what they feel is aesthetically proportionate. Okay. I've gone through part of this. We really don't have that perfect implant yet. And since we're talking about it, there are a few implants that we do not have in use right now that I will tell you. There is one that has been dubbed the gummy bear implant. Have you guys heard about that? It is silicone, but it is a silicone implant that if you were to cut it, it's sort of like a gummy bear. There's nothing that oozes out. The silicone inside is not like a gel. It is pretty cohesive. Europe has been using those implants for a very long time, but as you know, we have an FDA here, and the process, which is a good thing, I think, the process is very, very long to get an implant or any medical device approved. And so it is still in that stage, and there are some clinical trials that are going on. I have not used the implant myself, but what I have heard is it isn't the same consistency as a silicone. Obviously, it doesn't have the problem of rupture. However, with it, you don't have the issues of wrinkling like you can get in some saline implants. However, it doesn't feel like a regular silicone implant in that you can feel the edges. It's a lot firmer. And it doesn't really move. It's much firmer in terms of the shape, etc. So that's one implant that probably eventually will be available on the market. And then I saw a wonderful implant at this meeting again, and it is probably, I would say, I bet you it's 5 years up the road. But it's a saline implant, and what they did was, I don't know if you guys are familiar with water beds. You know, you can either slosh it around just like our saline implants are now, or you can put little like compartments in it so that you still, it's a different kind of a feel, and it doesn't have that sloshy. And they developed a saline implant that has, it's sort of that idea. It doesn't have compartments necessarily, but it has layers of envelope. And it feels as close to silicone as you can get. I thought it felt wonderful. So I'm actually looking forward to that implant. Because as a woman with breasts, if I needed implants, I probably would tend towards a saline just because I wouldn't want to deal with MRIs and this and that. I mean, that's my personal. I do a lot of silicones as well because everyone is different in terms of what is important to them. But the silicone, the saline implant that should be out, within the next 5 years, I think is awesome. So that's newness coming on. All right. Feel is different. Saline implants definitely are firmer. Silicone implants, a lot of times, as long as capsular contracture does not occur, they feel more like breast tissue. But regardless of what the implant is, it depends on the amount of padding that you add on top of that implant, because any implant that we place is always underneath the breast tissue that the patient has. So if you have a B cup to begin with, it probably will not matter a whole lot whether you go saline or silicone. And the reason is you have some breast tissue which is padding over that implant. So you're going to feel the breast tissue before you get to the implant. So it's less of an issue. But if you have very little breast tissue, then it does make a difference in the feel. The saline definitely feels more like a bag of water because that's exactly what it is. And with saline in areas, especially on the side of the breast and on the bottom, there isn't any muscle coverage over those areas. And over a period of time, you can definitely feel some waviness in the envelope of the saline implant. And that can be bothersome to some people. So that would go along with some of the differences. The rate of capsular contracture is actually higher around a silicone implant compared to a saline. We don't have very specific statistics on that, although we always try to get those. We know that it's higher, but I can't say. We tend to say that it's about 20% around the silicone over a lifetime. And then around the saline, we tend to say it's probably more like 3 to 7% maybe over a lifetime. But again, I don't think that they are as accurate as they might be maybe 20, 30 years down the road. Because we really started looking at all of these things as carefully as we have been over the last 10 years, in the last 10 years. Prior to that, we really didn't have any data or registry. And size of the incision is different because our saline implants do not come pre-filled. And so we can kind of roll them up and put them in and then inflate them, whereas silicones are already pre-filled. And so we have to have an incision that is large enough so that we are not causing trauma to the implant. Okay, we can't squeeze it in through a hole that big. Smaller the implant in silicone, the smaller we can make the incision. But if we're going larger implants, a lot of times we have to make an incision 5 to 6 centimeters, which is going to be, about 2.5 inches probably. So, I'll answer any questions, but then I want to show some photos. And the photos are really to give you an idea of how different we all are. And depending on what we start out with, obviously, really determines whether we can go with straight implants, whether we need to do something more, i.e. we need to do a lift. Because implants in general take whatever we're starting with and they just push that breast outward. It does not correct any kind of a sag. And therefore, in situations where we have sag, then we really do have to take care of that. Otherwise, the breasts look very unattractive. They look worse than without the implant, I think. So just a variety of different breasts. Sometimes we have asymmetries. And what's really interesting about plastic surgery in general is that a lot of patients will not notice asymmetries before they come in. Of course, it's the plastic surgeon's job to point out those asymmetries because some of those things we cannot correct with implants. But what is also very interesting is that all patients, whether it's for breast or anything else, after an aesthetic procedure, they truly will stand in front of the mirror and they will compare right, left, millimeter, up, down. It's just the way it is because we're doing aesthetic surgery, and so we do want them perfect. And it's just human nature to do that. So But asymmetries are important, and for anyone that's thinking about breast augmentation, to really look and see how things are. So, in a patient like this, if we were to put just implants without doing a lift, basically we would have the mound of the implants, and then we would have the rest of her tissue kind of hanging off of it. And typically when we do implants, most patients that I know want the breast to look nice. And when we think about nice looking breasts, and believe it or not, plastic surgeons and a variety of other, plastic surgeons in general, they look and they say, okay, the aesthetically pleasing breast is such and such, and the nipple-areolar complex is so many, centimeters, etc. And so there are studies on all of this in terms of what we generally look at and say, what is the pleasing breast? And we don't like sag. And sag is defined as breast tissue that falls below the fold underneath the breast. And that can be actual breast tissue, or sometimes it's just a nipple that falls below it without a lot of the volume. So she is one that has lost volume, obviously, but the sag is from pregnancy. So I don't know if you guys have kids. Me too. So the sag goes along with the pregnancy, unfortunately, for most people, and the loss of volume after the pregnancy. Sometimes people have very little breasts and very little volume. So this would be the patient where they really would feel the difference between a saline and a silicone. So as we're talking about this, in a patient like this, because there's so little tissue, I would be very, very hesitant to put an implant on top of the muscle. Because the muscle that we use is the pectoralis muscle, and basically it's a fan-shaped muscle that goes like this. It starts out here and it comes across and attaches to the sternum, and it is only the upper portion of it. And the reason a lot of times that we go underneath the muscle is because we want some padding up there. It makes the implant look more natural. It doesn't, you've seen, I don't know that I have any to show you, but perhaps you've seen some that have the step off right here. This is just very distinct, and you can see chest and then implant, mound. And so if we go underneath the muscle, it really eliminates that look, and that look is not necessarily very pretty sometimes. And in addition, what I have found is that with all patients, regardless of what's going on with the breasts, the most important area that people really want to look pretty is right here. This is the most important. We don't want any creases. We don't want any waviness there. We want it to look full, and we want that area to look as symmetric as possible. Because even with other asymmetries, as long as we can get that symmetrical, patients tend to be happy. Okay, so that when there are asymmetries, that's what I look to see. What can I use and do to get that symmetric? This patient actually has saline. Silicone, came out about a year ago. I lose track of time, but prior to that, we really didn't have silicone to use. So for augmentation, straight augmentation patients, we did all saline. And that was from 92 until like 2008, I think, is when they reversed it. That's a long time. So the majority of these patients are saline, and as you can tell from up there, you really can't tell the difference. You probably would be able to feel a little bit, because, especially on her, because she has so little padding on its own. But the look is not very different at all. When we get to a patient like this, again, there's no way that you can just do implants, and this is from major, major weight loss. And in this kind of a patient, I also don't like to do the lift along with the implant at the same time. And if there's significant lifting that needs to be done, what I have found over the years, and I used to do them together, but what happens is that the two work against each other, because when we do a lift, we're removing excess skin, and we want all of the breast tissue to go above the fold and sit and go back up to where it belongs. We're creating an envelope of I'm going to say, we're creating a skin brassiere over the volume that they have left. So we want everything held up there, and we don't want anything pushing down on it. We want everything to heal in that way. If we put an implant in, with the implant, the pocket that we create, we don't want the implant to sit up here, so we tend to push down on the implant so that it sits down below. So if we do the two in combination, what happens is they really do work against one another. And ultimately, what we want as our end result is we want symmetry. So we want the right and the left side to heal the same way. And we want them to heal in the way that we envision it. So when we do it in combination, what we find more often than not is that they don't heal the same way, and that we get asymmetry more often than not that needs to go back into surgery for revisions. And the other thing that is absolutely true is if we have to go back in for a revision, it's a lot harder to correct it as opposed to if we can get it to heal in the way that we want to initially. And so I have probably at least 15 years ago, if a person needs both procedures, I separate them. And in her, would do the lift first, let everything heal, and let gravity and laxity that occurs over a period of time happen, and then I can go back and put the implants in without impacting the way that the lift is going to heal, excuse me. So that is the way I approach it. The disadvantage to that is that it is 2 procedures, but like I said, there are a lot of patients that have to undergo 2 procedures anyway. When it's a revision, it's just not as easy to get what we want revising something that hasn't healed right as opposed to getting it to heal correctly the first time. This is the same patient that I just showed. Big difference. Sometimes we have asymmetry. Excuse me. And one side is small, the other side is larger. But there's sag involved as well. And so a lot of times if we have sag, we really don't know exactly how much volume we have, because a saggy breast always looks smaller than if we were to lift everything up into position, then the volume tends to look a little bit larger. So in situations where we have 2 sides that are so different, what I have also found over the years is that obviously we have to do a lift on the left side, on her left side, and we could do a lift on the right side as well, and then use 2 different size implants, right, because the volume is different. But if we do that, what I have found is, even though we're trying to do it for symmetry, our own breast tissue ages very differently than implants do. So in a patient like this, if we don't get the volume of her natural tissue similar, and we do a lift on both sides and use 2 different size implants, what happens is that it isn't too far down the road, perhaps a year, and they look different again. Perhaps not so much in volume, but they look very different in just appearance, because the breast tissue is so different from one side to the other and it ages differently. So in patients like this, again, I do 2 stages, but what I do is I get the volume similar. So on her, a reduction on her, see what I've done? I've lifted her left side and I have reduced her right side. Do you see it? So we start out there, and then if at that point she wants an implant, then we can place the same size implants. And what happens in that patient is that, and I don't know if I have the pictures up here, but I have a number of those patients, and if you follow them out for years and years, they are symmetric. And that's ultimately, that's what we want. So on this kind of a patient, we don't really need to do any kind of a lift on her left side, but because she is quite saggy on her right side, then we can do a little bit of a reduction, but also the reduction is a lift anyway, but we're also removing some volume, and we can get her more symmetric. And here she is at, I think it says 11 months. So those are all the photos just because of our technical difficulties, but there are albums in here that you can look at, a number of different ones, or I can email, whatever, and if you need more in terms of photos. You can talk to patients if that would be helpful for you. And I think any plastic surgeon would give you patients' phone numbers and so forth for you to be able to talk to if you have specific questions to patients that have implants, saline or silicone. You guys, but what else can I answer? There are pros and cons. So the most common incision is the one that is like in the fold underneath the breast. And I'll go through reasons in a minute, but that's the most common. And the second most common would be an incision that is right around the areola, not, the nipple part. And third is probably going to be underneath the arm. And fourth is through the belly button. Have you guys heard about all these? Okay. A lot of surgeons pick the ones that they want to do, and a lot of times everyone has their own reasons as to why they do one versus the other. For me, I truly, except for through the belly button, I've never done that, but I have done all of the other 3 incisions on many patients. Why I typically use the one that is in the fold underneath the breast is multiple factors. One is, again, as a woman with breasts, there isn't a way to exactly determine what someone's scar is going to look like. There's a genetic component to it, but there's a healing component to it as well. And even though there are very few patients that have unacceptable and or ugly scars, but what if we didn't know that that was going to happen and that was either in front of your breast or under your arm? For me, that would make me very self-conscious for anything that I would wear sleeveless. And also if I was in a locker room situation and I was getting dressed, I would be self-conscious. That's my personal opinion. So that's number one. Number two is when we place implants, it does not make sense to me to leave scar tissue in the breast tissue, our natural breast tissue, and then to go sort of through the breast and underneath the muscle to make the pocket for the implant. Or even if we're just going underneath the breast tissue, it just doesn't make sense to me. Because of the incidence of breast cancer, in addition to that, we know that bacteria exposure does play a role in capsular contracture. We know that. We also know that most of us, like 85% of us, without any kind of infection, have bacteria in our breast tissue. And that's because our breast tissue communicates to the outside world through ducts and through the nipple. So knowing that, it just doesn't make logical sense to me to go that way. When we go underneath the arm, in addition, there just is not, there are certain things that you have to do, especially going underneath the muscle. And part of that is there are some fibers of the muscle that come down onto the ribs down here, and those need to be divided. And so if you go through the underarm, you just don't have the same kind of control as you do with a direct exposure. If you develop capsular contracture, you kind of have to make that incision underneath the breast anyway. So for all those reasons, that's the most common one that I use. But I tell patients, and if there is someone that wants it a different way, through the nipple, no problem, I could do it. I've done lots of them. If it's through the armpit, basically, I have not done very many of those, and the ones that I did were many, many years ago. And so if someone wanted that, I think the one plastic surgeon that I know that consistently, for majority of his, does it that way is David Stevens. And so that's who I would refer to. And I don't know of anyone that's going through the belly button. That just doesn't make any sense at all. There's no control of the pocket, none. And so you're kind of just keeping your fingers crossed and going, well, hopefully we'll get symmetry. That doesn't make sense to me, so. Okay, so those are the incisions. Any other? Questions?
How do you know personally if it's lift or implants that you need? Is that part of the consultation?
It is part of the consultation, but for you personally, if you were to, try to predetermine, it has to do with the fold underneath your breast, and you have to look at or any part of your breast tissue below the fold. If there is a lot of it, the breast implant really can't be placed lower than the fold. I mean, we can go down a centimeter or so, but we really can't change that very much. So if we place an implant in a breast that has significant sag, the breast implant mound sits like at the fold and above. And then if you have all this tissue that is below, then all that tissue still hangs off of the mound of the breast tissue. And I actually have a picture in the exam room that I can show you to sort of give you. So Those were,
exact to
I
me,
agree.
so it's like, yeah.
I totally agree. You got it.
Sorry.
And then the other thing is the position of the nipple. So if the position of the nipple is either sort of at the fold, you know, if you look at it this way, or below, then that's sag. If it's at the fold, that's a little bit, I mean, that's sort of borderline. And for some people, as we age, we think that that looks more natural because of our age. And so that would be acceptable because there isn't this like you have to have a lift. And for those borderline ones where you think that it wouldn't bother you, like where your nipples were, for instance, you can always have the implant put in first and then decide if you need the lift or not. Yeah, if you need the hike. That's right. So it's not always 100%, but you can go in either direction in some cases. Not with, yes, some of the ones I showed you were real severe. To make a point, you know? Any other questions?
What's the recovery time or?
I didn't cover that. The recovery is, first of all, let me back up. It doesn't matter whether we do breast implants or any other surgery, or whether it's elective surgery or non-elective surgery. All of our bodies and our healing process basically is a 6-week process. And so it's that magical 6 weeks, whether you break a bone and you wear a cast, guess for how long? 6 weeks. Or if you have breast surgery, you know, how long are the restrictions? 6 weeks. Part of that is because as we heal, we lay down scar tissue. And that scar tissue is laid down, laid down, laid down, but it doesn't get very strong initially. And so anything that we do during that time period when it isn't very strong, we can tear it. Especially with elective surgery, when we want everything to be as predictable as possible, we want that optimal end result as perfect as possible. If we're doing things that are too early, earlier than the 6 weeks, we increase the risk of asymmetry, of areas of the scar tissue that get torn so that your body has to put new scar tissue in that area, so you have uneven scarring, etc. And I'm talking internal because that's ultimately, we want the internal to heal well as well. So healing as a general rule in terms of getting back to exercising, etc., is 6 weeks. Now, in terms of what you will feel like, the first week is probably the most difficult, and I'm going to say the first night is probably where you feel the most discomfort. The ones that are on top of the muscle are not painful at all. The muscle is what causes the discomfort after breast augmentation. And why it does that is that every muscle in our body has a resting length, and it's used to it. It's been living there forever. So we stretch it out and put an implant underneath it. It doesn't like to be stretched out like that, so it spasms trying to get to its shorter length. And it's the spasms that feel uncomfortable. They're like Charlie horses, or, you know, that's what it feels like. So for the first week, and then for the second week, it actually is much less, but you'll still feel the spasms a little bit, and by the end of the second week, you really feel pretty comfortable. Pain medication and muscle relaxants are important, especially for the first week. Some people take it for a few days and then they're fine, but I think some of it has to do with how strong is that muscle and how big is the implant. Those are the two factors. One breast always, always, always is a little bit more uncomfortable than the other. Who knows why? It has no correlation to whether you're right-handed, left-handed, nothing, but that's just a given. And but it all evens out. The other is that the look of the breast will change over a period of time because of gravity, because of scar tissue that becomes strong and then it softens again, etc. And so with all of that, regardless of what the breasts look like initially, because they always look a little bit too heavy up in here, those calm down, and it typically takes about 3-4 months for you to see the end result. And if I,
Larger, they look larger.
they look fuller up above, and they settle down, and so you lose the fullness in here, and they become a little bit rounder on the bottom as time progresses. And I actually truly, I have some photos of implants that are like early on, and then I have them at like, you know, 5 years, and you'll see the difference up in here. So. But I don't have them to show you, I'm sorry. Technical difficulties, so.
Outpatient surgery.
Outpatient surgery, it is, for me, it's done, I have an operating room here in the back, and it is done under anesthetic. And for me, overlake anesthesia, the same board-certified anesthesiologists that give anesthesia at Overlake come to this office as well for all of my surgeries. It usually takes somewhere between, I'm going to say, an hour and 15 minutes to 2 hours, depending on what kind of asymmetry we're dealing with, etc. It will take you about an hour to kind of wake up and recover, and then you get to go home, but you can't go home by yourself. You have to have a caretaker, and because they need to give you TLC and make sure you're okay. And with that, for me, I always give my cell phone number to the caretaker so that you can reach me directly at any point if there's a question or a concern. I always see patients a day after surgery, and basically I'm looking for bleeding, because bleeding can occur, and if it occurs, most commonly it's going to be in the first 24 hours. However, it can happen up till 2 weeks, because that's how long it takes our body to kind of seal off all those blood vessels that were cut in making the pocket. So I'm looking for bleeding and then answering any questions that you may have that first day. And then I start seeing patients on a weekly basis the first week and then up through the 6th week. And the reason is that that healing process, the 6-week healing process, the pocket that I make for the implant, I do a little bit larger than the implant itself, because I want it to move around so that it looks more natural. And in that initial phase, starting at a week, I have you move or slide the implant around to keep that pocket larger. Because anything in our body, if we have a pocket and there isn't anything keeping it open, we will seal it back together. That's just the way we heal. So we don't want that to happen. So I'll have you move the implants around. And the reason I see you once a week is if you're not moving one side quite as well as the other, we don't want that scar tissue to get strong. I can open it up for you so that we maintain the symmetry in the 2 pockets. Because if I didn't see you until the end of 6 weeks, the only way I'd be able to do that is take you back into surgery. So. But in terms of the discomfort going back to that, it really is about the first 2 weeks. It's very rare that anyone is on pain medication or anything beyond that, beyond the 2 weeks. Although, you know, pain tolerance is very different from individual to individual, huh? Yes? Yes? Oh. So, what else can I answer? It's a good thing she's here. She's asking all the questions, you guys. You're freeloading off of her questions.
Thank you. Oh, I think I do have one.
All right.
So it says that it's recommended if you were to do silicone to replace it once every 10 years?
Mm-mm.
Or it's not?
Mm-mm. They did before they came up with the studies. Before silicone came back on the market, what they were finding is that a lot of the silicone implants after 10 years, it seemed like there was more of them that were ruptured after 10 years. And so just a blanket statement, they said if you have silicone implants, you should probably get them exchanged every 10 years. That was prior to all the studies. So now, what they recommend the MRI, so that you're going to know if it ruptures and you don't need to do anything in terms of the 10 years. They've taken that away as long as you keep up the MRIs.
So same goes for them with saline. Unless it ruptures, you don't have to get it replaced.
Yep, saline, and correct. Saline, you don't have to do MRIs, because if it ruptures, trust me, you'll know. You will know. It's like a bag deflating, like a balloon deflating, basically. But a slow process. You know, unless it ruptures, or unless something like that, then, or capsular contractures are another reason to go back in surgically. And that actually reminds me, for all patients, if you are thinking implants, you have to go into it stating, this is what it's going to do in terms of benefits for me, but I know that I'm going to have more surgery sometime in the future related to my implants, period. When? We don't know. How many? We don't know. Most likely reasons for further surgery would be the 2 things that I mentioned to you, capsular contracture and rupture. But you have to go into it that way. It's not realistic to say, I'm going to have these and they'll be good until, until the end of life. It just doesn't work that way. So that's the other thing to sleep on and to consider if you're thinking about implants. Any other questions? That was a sad note. That we don't want to end there. No, we don't want to end there. There are truly millions and millions of women with implants. And so in terms of concerns, is it going to impact your body, your health? No, it just doesn't. So from that perspective, there really isn't anything to be concerned about. But anytime we do anything electively, we really do have to have all of the information and make sure that we know what it entails, what the trade-offs are, so that you can make really informed decisions as to whether the surgery is for you or not. And that's the important part. If there was, if anything about the implants or for anything that I do, if it was harmful to women, in this case, there's no way I would do it. I mean, there's just no way. I would feel totally comfortable getting an implant myself. I don't need one, 'cause, God gave me enough or something like that, but I truly would feel totally comfortable. And I think that's important for people to know as well.
I have a question.
Yes?
So when it comes to breastfeeding, so I've heard that you can't breastfeed, or you don't have the ducts to be able to breastfeed if you have implants, etc.
Wrong. Who gave you that information? No.
Oh, do they? Oh, okay.
Not true at all. No, that's a very good question. I actually get that. That's a very good question. I get that question a lot. Because the implant is underneath all of the breast tissue, it does not impact your ability to breastfeed at all.
Is it the same for just getting a reduction in lift too?
Those are different because you have to cut around it, yeah. It depends on how much of a lift, etc. And with both of those procedures, there is still some breast tissue and ducts that are going up to the nipple.
Okay.
But whether those will be enough to breastfeed or not is questionable. So whenever we do lift or reduction, I tell patients be prepared not to be able to breastfeed. If you're able to, then that's a great surprise. There's probably at least a 50% chance that you won't be able to after a reduction or a lift, not implants by themselves, not at all. The other question that I get, see, you're making me think of some questions that I get as well. People ask, if I have an implant and I get pregnant, what happens? Nothing. Basically, your breast will react the same way that it would normally with the hormones that overtake our bodies when we're pregnant. And typically what happens is that you get engorged, obviously, during the pregnancy, and then milk production, etc. All of that will be completely as it would normally. Now, the one thing to consider is that obviously if you didn't have the implants, all of that would create a smaller end result than with the implants, right? And there are some people that go up to like G sizes when they're pregnant. And so I know there's the 3 that haven't been pregnant. I see that. Honest to goodness, there are some people, and with that, obviously with an implant, they're going to be even larger. That's an extreme, though. So, but that's really the only change. The other thing is that implants will not prevent the sagging that goes along with the pregnancy.